is Nonthalee Pausawasdi. I'm the president of the Thai Association for GI Endoscopy. I'd like to thank AWE and Women in GI Network Asia Pacific, known as WICNEP, for the opportunity to be part of this program. It is my pleasure to deliver a talk entitled Expanded Interventional EUS Indications. Currently, interventional EUS has a role in drainage of pancreatic fluid collection, bile duct and pancreatic duct obstruction, and gallbladder in acute cholecystitis for patients who are not surgical candidates. Besides from drainage procedures, ablation therapy of pancreatic cystic and solid lesions, injection therapy, and implantation of fiducial markers and I-125 seeds can be delivered through interventional EUS. Also, creation of luminal anastomosis such as gastroenterostomy or enteroenterostomy can be performed using EUS. Today, my talk will focus on the emerging devices and techniques beyond the drainage procedures for pancreatohepatic and biliary indications, including pancreatic necrosectomy, stone extraction, and anastomotic stricture dilation, and surgically altered anatomy, and bile duct reconnection using magnets, an age procedure. I will also cover EUS guided gallbladder drainage and cholecystoscopy guided interventions. Starting out with wall of necrosis management, the treatment strategy of wall of necrosis includes the use of luminiposing metallic stents or LAMS. LAMS should be removed within 3 to 6 weeks, and double pigtail stents can be replaced. The timing of necrosectomy is debatable. Step-up approach is recommended, but direct endoscopic necrosectomy can be considered in selected cases. Multi-gateway drainage can be considered for multiloculated lesions, and combined percutaneous and endoscopic drainage should be considered in an extensively spreading lesion. Here is a video demonstrating wall of necrosis drainage using a multi-step technique with cold spaxes. Starting off with puncturing of the lesion using a 19 gauge FNA needle, followed by insertion of a guide wire. A .035 guide wire is being used here. Once the wire is being placed inside the lesion, then the needle is being removed, and the tract is then dilated using a 6 French cystotome, followed by a hurricane balloon dilation. In this case, we use a 6 millimeter hurricane balloon. Once the tract is being dilated, then a luminiposing metallic stent can be placed, and the internal flange is being placed under EUS view, and the distal flange is then being deployed under endoscopic view, and you can see in this case that large amount of fluid is being drained after the stent is placed. For an extension of wand to paracolic gutter, a combined endoscopic drainage using a hot axios as demonstrated here, and percutaneous drainage can be performed as demonstrated on this slide. You can see that the stent can be placed through the skin, and the paracolic gutter collection can be drained through here. Many devices can be used for necrosectomy, including a snare, rat tooth forceps, rod net, and grasper. The endpoint is the presence of granulated cavity, as shown here. Then LAMS can be changed to multiple plastic stents to keep the tract open. Besides from using bigger sized LAMS with cautery tip, new devices have been introduced for effective necrosectomy, as shown in the right lower corner here, including endorotor or other devices. I'd like to spend a few minutes talking about the endorotor. Endorotor is a novel automated mechanic endoscopic resection system with cutter speeds of over 1700 rounds per minute. The catheter is compatible with endoscopes with a 3.2 millimeter working channel or larger working channel, and a large international prospective trial has been conducted to evaluate safety and efficacy of the endorotor. As shown here, more than 70% of necrotic debris were removed within 21 days. The authors concluded that this device is safe and effective, and it's associated with lower number of endoscopic sessions and shorter duration time for the procedure compared to published data. However, a head-to-head comparison with standard device is required. Moving on to another indication for interventional EUS, which is the treatment of benign hepaticojejunostomy and anastomotic stricture. Conventionally, surgery, percutaneous approach, and balloon-assisted ERCP have been established treatments modalities for this problem. However, with the EUS technology, this condition can be treated as well through the EUS. This video demonstrates the creation of gastro, um, uh, sorry, this video demonstrates a creation of the hepaticogastrostomy tract, and a fully covered metallic stent can be placed through this tract. That's the first step to start doing when we try to treat the hepaticojejunostomy stricture dilation. So after creating the hepaticogastrostomy tract and place a fully covered metallic stent, the fully covered metallic stent can be removed and replaced by multiple plastic stents as shown in this video, and the plastic stents can be placed at 4 weeks after the fully covered metallic stent is removed. And through the hepaticogastrostomy tract, the intrahepatic duct stones can be treated with laser lithotripsy, and the stricture can be treated as well through the hepaticogastrostomy tracts. With the same concept, the EUS guided procedure can be used for treatment of separate right and left duct in patients post hepaticojejunostomy Roux-en-Y. This cartoon here demonstrates that the left intrahepatic duct can be accessed through the hepaticogastrostomy anastomosis, whereas EUS-guided duodenojejunostomy anastomosis can be performed to allow an access to the right intrahepatic duct. And once the right intrahepatic duct is reachable via DJ anastomosis, a stent, as shown here, can be placed into the right intrahepatic duct. The same concept can also be applied for complete hepaticojejunostomy anastomotic stricture with an addition of magnets to open up the anastomosis. And this can be performed by, number one, creating hepaticogastrostomy tract through the left intrahepatic duct as shown in this left panel here. And then the right intrahepatic duct can be accessed through the DJ anastomosis. And once the HGS anastomosis is being created, the proximal magnet can be delivered through this left intrahepatic duct, and the distal magnet can be delivered through this DJ anastomosis. Here is a video demonstrating a creation of duodenojejunostomy using a hot axios. And you can see blue water coming out, confirming the location. And once the tract is being generated, both the hepaticogastrostomy tract and DJ tract, then the proximal magnet is being delivered through the hepaticogastrostomy tract. As you can see on this fluoroscopic image, here's the proximal magnet being delivered through HGS tract. And then a lower magnet can be delivered through the DJ anastomosis. And once the two magnets connected, the biliary enteric anastomosis is being created. And as you can see here, you see this connection right here. This is what it looks like. And this anastomosis can be dilated using a CRE balloon up to 1 centimeter, as demonstrated here on this video. The biliary enteric anastomosis is being dilated using a CRE balloon, followed by stent placement. Now, moving on to the next indication, which is EUS directed transgastric ERCP, or H procedure. H is an alternative to enteroscopy and laparoscopic assisted ERCP in patients with Roux-en-Y gastric bypass anatomy. The procedure involves the creation of temporary transgastric fistula by placing a lens that connects the gastric pouch to the excluded stomach, facilitating antegrade ERCP access across the new tract. As you can see on this cartoon here, the gastric anastomosis is being created using hot axis, and then and duodenoscope can be placed and traversed across the new tract, which is a normal track that we would do for USDP, and the ampulla can be accessed in a normal fashion. The outcomes of this procedure have been reported in a multicenter retrospective study, including 13 US centers. The technical success was 98%, with the mean procedure time of 92 minutes. The peri-procedure adverse events was about 16%, with 10% having persistent fistula. However, 5 out of 9 patients were treated successfully with endoscopic suturing. This procedure seems to have a promising future if the adverse events can be minimized. Moving on to the next indication, which is EUS guided gallbladder drainage in acute cholecystitis. There are 3 methods for gallbladder drainage in non-surgical candidates, including percutaneous, ERCP, and EUS guided. The pros and cons of each technique are shown in this slide. For percutaneous route, this technique has been done for several years. We're all familiar with it. And the advantage of this procedure is that it's readily available, and we are very familiar with it. However, the patient's gonna have a transabdominal catheter, which can be uncomfortable, and the re-intervention rate is quite high, whereas a ERCP can be challenging if the cystic duct opening is difficult to identify. EUS is going to require an additional skills and expertise. It's not widely available, and that's a drawback of it. However, the re-intervention rate is quite low. So each procedure or each technique has pros and cons. A systematic review with network meta-analysis comparing the 3 modalities have been conducted. Percutaneous approach has the higher technical success. However, it also has highest re-intervention and unplanned admissions, whereas EUS has the highest clinical success and the lowest recurrent cholecystitis rate, but with the highest mortality based on this study. From the technical standpoint, a transduodenal approach with a single step device is a preferable method for EUS guided gallbladder drainage. And here are some devices and accessories to be used for the gallbladder drainage. The procedure involves puncturing of the gallbladder using FNA needle, 19 gauge, wire placement, dilation of the tract, and stent placement. However, if we have a single step device, all these steps can be combined into one step, and it's a lot easier to do. And the currently available device are hot axios or hot spaxes. They work really well. And through the cholecystoenterostomy tract, cholecystoscopy can be performed to remove the gallbladder. Laser lithotripsy can be used to break down the gallstones and remove through the cholecystostomy tract. Or the mechanical lithotripsy can be performed. Also, a basket can be used to remove the stone through the EUS-created cholecystoenterostomy tract. To expand the horizon of interventional EUS, device refinement and adequate training through hands-on or or training models are required. Here I'm showing you some of the models for therapeutic EUS created by the Thai Association for GI Endoscopy, or TAGE. The first one is a pseudocyst model. The second one is the hepatico gastrostomy model. This model will allow you to actually identify the dilated intrahepatic duct and puncture it, and place either plastic or lamps. Here's a model for choledochordodenostomy, and several workshops have been conducted. Finally, I'd like to conclude that the indications for interventional EUS are expanding beyond just a drainage procedure. Most of the procedures are performed by experts. Procedures appear safe. However, the efficacy and long-term outcome data are needed. Refinement of the devices and proper tuning are required before one takes on this type of the procedures. And with that, I'd like to thank you very much for your attention. I'll be happy to answer any questions. Thank you.